hear that term a lot. I just wanted to clarify what is a hilar hernia, because most of the time in the clinic when we talk to the patient, they just don't know. So what hilar hernia means that part of the stomach will move upwards a little bit inside of the chest. So part of the stomach will be inside of the chest, and most of the stomach will be in the abdomen here. So in some severe cases, we can even see an interthoracic stomach, meaning that the whole stomach has migrated upwards to be inside of the chest. And when this happens, of course, this is also another factor that will facilitate reflux to happen. So what are the symptoms of gastroesophageal reflux? Basically, anything under the sun. The most common symptom is heartburn, and we call this typical reflux syndrome, like heartburn, regurgitation. You feel the actual movement of the fluid upwards inside of the chest. Now, chest pain is considered as a typical symptom of acid reflux, because most of the time patients do not really discriminate or differentiate between heartburn and chest pain. So whenever there is a chest pain patient, I get a lot of chest pain patients in the clinic, first thing we should do is to exclude the heart cause of the chest pain. Once this is excluded, this should be called non-cardiac chest pain, meaning chest pain not caused by the heart. And 50% of the time, this could be caused by reflux. Other symptoms of reflux, those are called extraesophageal or atypical symptoms of GERD, meaning that GERD could be the cause, but it's not the primary cause. So, for example, like cough. When someone is complaining of cough, reflux is not going to be the first thing that comes into your mind when someone's complaining of cough. But it could be the cause, yes, in minority of the situations. Laryngitis, inflammation of the larynx. Asthma can even induce asthma. But all of these are called atypical symptoms, meaning that it's rare, but it could be caused by acid reflux. Also dental erosions, sinusitis. In severe situations, pulmonary fibrosis, pharyngitis, otitis media. All of these are called atypical symptoms, meaning that reflux could be the cause, but it's not the primary cause. Okay, what else could be caused by acid reflux? Belching. The relationship of belching to reflux disease is variable, but belching is actually a form of reflux. We have two types of belching, something called habitual or supragastric belching. This is not reflux. And something else called gastric belching, which is actually reflux of gas from the stomach upwards to the food pipe or esophagus. Video doesn't show here? I have a video here.
A video.
Yeah. Maybe.
طب هو اصلا احنا لازم الاول نشوفه هنا مش ممكن فيه.
لا ما هو بنعمل خلاص مش مشكلة.
كلنا
No problem. You can just skip it. Well, this was a video to doesn't show for this. ممكن تعال يوتيوب ان شاء الله ممكن.
بلاش اليوتيوب.
ليش؟ خلاص ماشي. Okay. Well, this was a video was intended to show the difference between gastric reflux and supragastric reflux. It's basically just those like fancy terms. Gastric belch, Gastric belch meaning that it's actual movement of gas from the stomach, and this is considered reflux and should be treated as reflux. And the supragastric belch is a different form of belching, and this is habitual. And we do a certain test in our lab to differentiate between both. If someone is complaining from frequent belching, they should consider reflux as the cause of their symptoms. And if it's impacting his quality of life, it's happening more frequent in public, So this should be investigated because the treatment could be very simple, and the treatment of belching is actually the same as treatment of reflux. Okay, so with reflux, the most common medication that we give to treat reflux is they are called PPIs, proton pump inhibitors. So with proton pump inhibitors, they suppress the gastric production, the acid production in the stomach. But as we just explained, when we think about reflux, we should all think that reflux is a mechanical phenomenon. It means that the muscle that protects against reflux, that separates the esophagus from the stomach, became weaker or like allowing more reflux than it should be. But PPIs, the proton pump inhibitors like Nexium, Prilosec, Dexilant, all those medications, these medications doesn't stop reflux from happening. It will just make the reflux material less acidic. But reflux will keep going on. I mean, it will not prevent it or not stop it, because those medications doesn't change the mechanism of reflux, doesn't fix the mechanical issue here, doesn't fix the sphincter. So here, this study was intended to compare between Nexium or esomeprazole and lansoprazole, which is Prevacid. And both showed... That's 2 minutes. Yes? Okay. I'll have to run. It showed that those medications are effective in about 60% of the time. So in 40% of the patients, they will be refractory to medications. So all of those medications, like what I just described now, Nexium, Prilosec, Prevacid, Pantoprazole, Acifex, they will not change the mechanism of GERD. They will just make the reflux material less acidic. Also, when someone is not responding to medication, it could be something else other than GERD. Like this is a rare disorder called achalasia. So when you're complaining of heartburn and you're not responding to PPIs, you should get investigated, because it might be something else entirely. A different disease is called achalasia. It will cause you to have heartburn. In advanced stages, it will cause you to have swallowing difficulties. So how to diagnose reflux? First, we will do a test called the motility test. Basically, it's not the most comfortable test on earth, but you should consider this as a dentist visit, because you have to be fully awake. And probably Dr. Well has experienced this. So we need to put this tube through the nose and to reach the esophagus. The tube has sensors. It will capture the esophageal movement. So it will tell me if the esophagus is able to squeeze well or not, if there is any issues with the movement of the esophagus, if there is any issues with the sphincter or the muscle that we just talked about, and it allows the reflux to happen more frequently. The second test that we do is called the pH impedance test. It's basically we measure the pH in the esophagus in 24 hours. This should be easier because the tube here is much smaller or much thinner. And this test will be considered as a snapshot of a normal day. Actually, when we put that tube in, we encourage the patient to eat normally and even eat fatty meals, because I want to have a snapshot and I want to see what's going on in 24 hours. Also with endoscopy, in severe cases, we can see inflammations in the esophagus. This is how we treat acid reflux. We talked about the spicy food, fatty, carbonations, coffee, chocolate, all these things should be avoided, and also with weight loss. This is controversial here. We encourage the patient to sleep on their left side, actually, with acid reflux, because when we sleep on the left side, most of the stomach content will be stuck here in the biggest side of the stomach. But if you slept on the right side, the stomach will be more in line with the reflux. So this will induce more reflux. So when someone is having severe reflux symptoms, we encourage them to sleep on the left side. We used to say in reflux, left is right. Those are the medications, the PPIs ordered based on their effectiveness. Same slide here. Also, with reflux, it depends on the symptom. So for example, if someone is complaining of heartburn, PPI should be effective. But if someone is complaining of regurgitation, it's 50% chance that they will get an effect on PPI. Cough, PPIs are not effective at all. hoarseness of voice. PPIs are not effective at all. This should be investigated. This is the two final slides. We just said that reflux is a mechanical phenomena. It's a weakness of the muscles that protects the esophagus. So the treatment, the definitive treatment, the best treatment for reflux is surgery, actually. This is one of the procedures that can help with acid reflux. It's called fundoplication. It's basically what we do here. We wrap part of the stomach around the lower part of the esophagus, so the esophagus will become, in the lower part, will become a little bit more stronger to guard against reflux. This is one of the procedures. This is another procedure called LINX. We put this ring, it's a ring of magnets around the lower part of the esophagus, and this will help to prevent acid reflux from happening. This is my mentor. He used to say, God put the esophagus in the back of the chest to keep it away from the surgeons. I disagree with this. Okay, thank you.
Thank you, Dr. Khaled. Thank you so much. We have 3 minutes for questions.
Very nice presentation, very informative for me as a lay person. I want to ask you one question. And this is what the Prophet ﷺ has said about eating. You know, when you eat, fill up your stomach 1/3, fill up with the another 1/3 with the water, and leave the 1/3 empty. So my question to you is this: if we follow strictly this teaching of the Prophet ﷺ, will you have the GERD?
So most of the time, GERD happens due to stretching of the stomach. So when you follow this teaching, the stretching will not happen. And when when GERD happens, the stomach gets stretched out, and then will be signals sent to the brainstem, and then back to the vagus nerve, to the lower esophageal sphincter, will ask the sphincter to relax, to vent that excess stretching that happened to the stomach. When we follow this teaching, this shouldn't happen. But this is like 80 to 90% of the time. In 10% of the situations, the sphincter, the muscle, is of no good anymore. It's so weak, and whatever you eat, we call it a common cavity phenomena, meaning that the esophagus and the stomach become like a common cavity. So whatever you eat, whatever you do, everything will just go upwards to the esophagus. And in this small subset of patients, there is no use to try with lifestyle modifications or with medications. This is a surgical situation and needs to be repaired by surgery. Okay.
Give last question for Dr. Islam.
Dr. Khaled, can you please comment on the lifestyle changes for acid reflux and the advices you tell the patient?
Well, we talked about briefly is to avoid carbonation, coffee, chocolate, fried food, fatty food, spicy. This is in terms of the diet. In terms of position, we advise, of course, not to eat and sleep right away, at least 3 hours between the last meal and when the bedtime, to elevate the head of the bed. And also with severe situations when regurgitation is so prominent, and some patients will usually wake up in the middle of the night choking or feeling regurgitation and out of breath, we encourage the patient to sleep on their left side, because this will will make the esophagus not in line with the stomach. Weight loss, of course, because when you lose weight, you reduce the pressure exerted on the stomach and the abdomen, and this will make reflux less likely. Basically, that's it. Weight loss, diet modification, and positioning, and the position during sleep.
Can you answer in a few seconds?
In sports, sports, it should increase the intra-abdominal pressure and produces more reflux. But also, but also I can't deny the fact that sports will help you to reduce your weight. I mean, It's a risk versus benefit ratio. I don't believe that sports are, should be avoided because of acid reflux. It should be encouraged and we should keep doing it because the benefits will outweigh any risks.
Thank you, Dr. Khalaf, for great presentation. We will.
One question, sorry.
Okay, go ahead.
Is there any complication, like if GERD is not treated, what other GI problems may happen?
So it will has a lot of problems. Cause injury to the lining of the esophagus. This injury will predispose to something called peptic stricture, so the esophagus will become narrower. And in severe situations, it could, and yes, it's a minority of patients, but it can happen. It can cause something called Barrett's esophagus. The lining of the esophagus will be predisposed to cancer, and in like 1% of patients. But I mean, you don't want to be among those 1%. Okay.
We lost the question.
Question done?
No,
Second
quick.
issue, clearly outline or explain the benefits of acid reflux with respect to PBT. One area I have not noticed you address is the mortality aspect. Does acid reflux suffocate people with severe cases and they die instantly?
So it's I wouldn't say it's a mortality issue. It's a morbidity issue. It impacts the quality of life of patients. And there was one study that showed that acid reflux implication on the quality of life is comparable to patients with ischemic heart disease.
Yeah,
Okay,
there are
yeah.
cases of people
Yeah.
dying instantly from suffocation.
Dying from suffocation from reflux.
Yeah.
It could cause aspiration, but those patients usually they have a lot of comorbidities together. So it's not like reflux is the cause of death, but it will just make the patient go into a vicious cycle. They have already bad lungs, and with acid reflux, it will just make this worse because it will make the lung fibrosis even more predominant.
Okay, thank you. Thank you. We have to keep the time. I'm sorry, but we have a hard stop at 5:45 because we have two different events follow this. So I'm sorry. Thank you, Dr. Khalaf, for great presentation. The information you shared was clear, practical, and truly helpful to our community. Now let's welcome Dr. Zia Rahman. He is a clinical professor at East Carolina University. He has over 20 years of experience in pulmonary disease, and he is a pulmonary specialist and sleep specialist at critical care and neurocritical specialist. Thank you.
Assalamu alaikum. Bismillahir Rahmanir Rahim. So let's start with sending blessings upon Prophet Sallallahu Alaihi Wasallam, because Allah and His Messenger send the blessings on him. So I will try to, I was told that already my 5 minutes have gone, so I will try to reduce the number of slides and I will try to keep myself to the basics. So,
You're okay. You're going to take 15 minutes. That's fine.
okay. So I will just go through the sleep physiology, the changes which we go through and how the sleep happens, and if we don't sleep, what happens, and how it impacts our life. So Muslims have been ordered in accordance with the practice of the Prophet Sallallahu Alaihi Wasallam that we should sleep early and we should rise early. Prophet Sallallahu Alaihi Wasallam has encouraged his companions not to be involved in any activity after Isha prayer, which we know around 1.25 to 2 hours after sunset. The Prophet Sallallahu Alaihi Wasallam also said one should not sleep before the night prayer nor have discussions after it, Sahih Bukhari. Additionally, Muslims are required to wake up for Fajr prayer, which is about 1 hour before sunrise. The Prophet ﷺ did not sleep after Fajr prayer. In addition, he sallallahu alaihi wasallam told his companions that early morning work is blessed by Allah subhanahu wa ta'ala. And the early risers are always ahead in life from the other people. So please try to teach your children, try to teach your household to get up early, and the morning time is the best time when your memory is the best. When whatever you try to memorize or read in the morning, you will retain it the best. So perform ablution, that's another one hadith. Prophet ﷺ told a man who was lying on his stomach that Allah dislikes it, but in some conditions, like when there was COVID, that it was recommended by the physician. So there are certain exemptions always. Islam is like, which is called like a practical, and it addresses the humanity in a positive way always. So in COVID, because of the ARDS, it was because there is like equivalence of oxygenation, and the people were asked to sleep prone. In fact, in ICU, intensive care unit, we still prone patients when they are very, very sick, and it's very difficult even if they are intubated and bring them their oxygen up. Dusting and cleaning the bed before sleeping. So just imagine like 1400 years ago, and like it was told to us, and if there is any insect or something, we should check our beds before sleeping that there is nothing in it. Also turn off light before sleep. So in the past, there were like oil lamps, like if you don't turn them off, there was a chance of getting like having fire. But also, if you see, there are some what we call zeitgebers, or there are some cues which make us awake. The biggest one is light. So if you wake up at night time with your, and please don't check your cell phone, what's going on in the world, because light is the biggest source which makes us awake. Don't check your cell phone, don't play with laptop in the bed, don't watch TV in the bed. Sleep hygiene, which I'm going to discuss in few minutes, is very, very important, which is like good sleeping practices. You can Google it and you will find it. And one of my friends just asked, like, the people have died with GERD. I think there is no data, but patients have died with sleep apnea. So there are patients who have like, they have pauses in breathing. If they don't use their CPAP machine or positive airway pressure machines, or they can die during sleep. If you Google, you will find some famous athletes and some famous persons have died during their sleep. And there are other complications which happen with sleep apnea. So why do we need sleep? Everyone needs sleep. Sleep is life. No one can live without sleeping. You can be awake for a few days and then we will be done. So the best record is, I think, 17 days. Only once, which is one of the Marines, could survive. But otherwise, after 2-3 days, everyone needs to be to sleep. Like in wars, they train people that they should not be sleeping for a few days. After 24 hours, we have the same amount of like activity and brain which we have after drinking alcohol. So if you have 0.08% of the alcohol in your blood, which is the above the limit of permitted alcohol in US, that is what we act like when we are sleep deprived for 24 hours. And after that, it becomes worse and worse. So sleep is required for energy conservation, is also required for memory consolidation. In fact, the sleep has different stages. This is known as non-REM and REM, rapid eye movement sleep and non-rapid eye movement sleep. Non-rapid eye movement sleep is again divided into 3 stages. So these stages are picked up by electroencephalogram. We put some leads on the brain and we can pick up the electric current, which will tell us different waves. So while we are awake, our brain generates different waves. When we are drowsy, it's different. When we go to light sleep, it's different. When we go to deep stage of sleep, it's different. And REM stage sleep is the most important, and that is also what we call implicit memory or the procedural memory, like driving and other, handling the machines. That type of memory is consolidated in REM stage sleep, and the other types of memory is consolidated in non-REM sleep. So also, patients have more dementia, Alzheimer's dementia, and other situations if they don't sleep, they are sleep deprived in the long run, because this is the glymphatic system. There is a system in the brain. When we are awake, there is some waste products of our metabolism which needs to be get checked and removed. So that's when we sleep and it happens. So also when we are awake, there is a compound known as adenosine, which develops in our brain. And if we take caffeine and adenosine are similar in structure. So that's why when we take caffeine, it can displace the adenosine from its receptors, and it can delay the sleep for some time. But in the end, adenosine will be so much that we will not be able to awake, and we will not be able to act independently. When children are born, they need like 14 to 16 hours of sleep. Teenagers need like 7 to 10 hours of sleep, but it's recommended by the American Society of Sleep Medicine that we need 7 to 8 hours of sleep. There are some short sleepers which can act properly with the 6 hours, and there are some long sleepers which need around 8 to 10 hours to act properly during the daytime. So normally it's not that the brain stops its activity. It's a reversible process, and it's disengagement and unresponsiveness to the environment with typical changes which we pick up on electroencephalogram. So it has these stages which we have already discussed. So when we sleep, there is a very light stage, and then stage 1, then we go to N1, N2, and 3, and then we go what we call rapid eye movement sleep. If you see, this pattern recurs, like you see awake, N1, N2, N3. This is the also called slow wave sleep, which is very, very important, which goes lower and lower with aging, and this is rapid eye movement sleep. It happens every 60 to 90 minutes. So as the night goes by, we have more of REM stage sleep than of non-REM stage sleep. And it has its own implications, and dreams and nightmares happen in different stages of sleep, and the terrors, night terrors, and arousals that the children like awake and they are crying and screaming, that happens in different stages of sleep. So this is again another model which states that when we are when we at 9 a.m. when we are awake, being awake, propensity increases. There are centers in the brain. It's a very regulated process. So there are multiple centers which regulate it. So then the sleep propensity also increases, but we are not sleeping because the wake propensity or wake signals are higher. So then at this stage, there are some centers which set up, and melatonin is secreted, which you can buy on over the counter, and sometimes patients use for sleep induction. So then the darkness sets in, and the wakeness propensity goes down, but even it's going down, then we continue to sleep. And at about 4 a.m., there is like a dip in the temperature also. So it's a very, very regulated process. And if you do a PET scan is like you inject something and you take pictures, and it will tell you which part of the body is very active. We do it for cancers also. We do it for lung cancer, colon cancer, but brain normally is showing like this. When we are awake, you see these are the areas active. In non-REM state sleep, and in REM state sleep, it's like more active than the awake state. So there are a lot of processes going on. So this is again showing that as we age, our sleep latency goes higher. Sleep latency is the time when we try to sleep and we can actually sleep, and there is wake after sleep onset. That goes higher too. And REM state nearly remains the same, but the slow wave sleep state goes down. So this is as we age, our sleep is less and less, and we can be, and also there are two important peaks of sleep. One is near the morning, and the other one is after midday. That's why we take sometimes naps. And this is another thing, when we sleep normally, our heart rate goes down, our blood pressure goes down, but if we are struggling to breathe, like snoring is partial obstruction. When somebody is snoring, there is obstruction. It happens mainly in the upper airway. So when we sleep, every stage involves relaxation of muscles. So when we sleep, if the oral anatomy is such that the tongue can fall back and obstruct the airway, so the patient will be struggling to breathe, and blood pressure and heart rate will fluctuate. With the passage of time, it has long-term consequences. Those patients have more heart attacks, more strokes. You can hear that somebody died during sleep, was having sleep apnea, did not wear his CPAP machine, especially if it's very severe and the oxygen is going down. So it's very important that we treat the condition, and we try to, if when we lie down on our back, that is the position. When in supine position, then we have this type of, when the muscles are relaxed, tongue will fall back. So that's why a snoring person, somebody will go and turn that person to the side, and the snoring will be less. A snoring person, when stops snoring, basically is not breathing, and when they have a loud snore. So that's another which we screen, and then we go like this is showing that the men are more affected than the women, but it changes after 50. And these are the conditions of the like consequences of sleep disordered breathing. So they have daytime hypersomnolence, that they have neurocognitive dysfunction, means memory dysfunction. They can have hypertension, myocardial infarction, heart attack, congestive heart failure, arrhythmia, strokes, metabolic dysfunction, and respiratory failure. And so my time is up. You can ask me questions. So basically, there are multiple interesting topics in sleep, and it cannot be covered in 15 minutes. There are parasomnias.
You can talk here, and if anyone. So we have 5 minutes of questions.
Can you please give us a comment about Prophet Muhammad Sallallahu Alaihi Wasallam used to sleep like for 4 hours, then he take, after 4 hours sleeping, he wake up for Qiyamul Layl, almost for maybe 1 hour, according to my understanding, then he sleep again for maybe 1 hour, and he offers Salat al-Fajr. Can you comment from your experience, how you look at it? And this is his whole life, Sallallahu Alaihi Wasallam.
So there is no study and there is no data on this, but normally, like as I said, what is recommended, that is like, and we don't know how long were the nights at that time. And Prophet Sallallahu Alaihi Wasallam, most likely maybe they were sleeping after 7 o'clock and they were waking up at 3. It's already 6 hours. So we don't know exactly how much was the time, or like, but sleep is very, very important. There is only one in the universe who does not sleep. And Imam knows. And in Ayatul Kursi, Allah subhanahu wa ta'ala is the only one who doesn't need sleep or slumber.
Taxes doesn't sleep.
Yeah, why?
Taxes. Taxes.
No,
Doesn't
no,
sleep.
otherwise like these horses, elephants, whales, they even like whale is in the sea, half of the brain sleeps and half of the brain is active. So Allah subhanahu wa ta'ala has put something that this brain needs to recuperate. It's
Jazakumullah khair. Jazakumullah khair.
For the older people, they sleep less. So, in your opinion, what is the minimum hours that it can be? 4 or 5 hours should be okay. And some people advise eating banana at night because potassium and magnesium and stuff. They say it helps sleep. Do you agree with that?
So I think it's a very important question which brings us to sleep hygiene. So we tell every patient that you should have regular sleep-wake schedule. That's number one. Number two, lights should be off, environment should be good, temperature should be good, no noise, don't watch TV in the bed, don't, like as the brother said, that don't lie down for some hours. If you are like having reflux, you will not be able to sleep properly. So no caffeine or caffeinated stuff after midday. There are multiple products which have caffeine. Even decaf has some caffeine. So avoid any caffeinated drop. And when you take multiple cups of caffeine in the morning, it has half-life which can go into the night. And it's like in elderly people, if they take a cup of coffee near the evening time, they will not be able to sleep. Otherwise, their total sleep time is nearly the same, like around 7 hours. They sleep sometimes in the midday, they doze off. If you doze off watching TV in the evening, your sleep onset will be delayed. So that's another, and it's best to have chemical-free sleep. I don't think bananas and magnesium will be helpful. But these practices and light exercise in the evening will be helpful. Having a shower before going to bed will be helpful.
Jazakallah khairan for your nice presentation, bringing some Islamic perspective also. I have 2-3 quick questions. Number one, is this recommended 7 hours or more than 7 hours sleep is a continuous 7 hours or is, breakup of that one?
So that is what I think.
Secondly, what is the clinically significant consequences if it doesn't sleep that long? And I'm asking you this thing because I read Imam Nawawi. He used to sleep, hardly sleep. And he died actually in 44 years his age. And we all know that his remarkable publication in that short life. He was hardly sleeping, or sleeping 2-3 hours, at the most. So with all of this thing, would you make a comment?
So I have been told only few seconds. So if we are sleep deprived, then there are a lot of complications, as some of them I already mentioned, that if we can have like myocardial infarction, strokes, we can have what we call metabolic syndrome, like we can have GI issues, we can have more accidents, but as far as like 4 to 5 hours, I think that was also asked by Brother Imam, and it's recommended is consolidated 7 hours of sleep, but it's always interrupted by something. There are patients who go continuously, and we ask that, like how many times you wake up, and when you wake up, how long does it take you to go back to sleep, and what does happen, whether it's going to bathroom or any other reason. So there are multiple other variables which can affect, but sleep deprivation, chronic sleep deprivation is very, very, very harmful.
Thank you, Dr. Dia, so much. It's very informative to share this information with us. Thank you. I appreciate your time devoted to prepare this presentation. And again, I'm sorry, we have 2 events after that. We have to adhere to the time. And we will have, if we have time, inshallah, at the end of the presentations, we can have all our speakers sit here and we can give you a chance to ask all of them together if we have like 5-10 minutes at the end, inshallah. But let's welcome our next speaker, Dr. Mahvish Muzaffar. Hope I pronounced your name correct, Mahvish Muzaffar. She is an associate professor and program director of hematology and oncology fellowship, and she has 12 years of experience at ACU. She will talk about breast cancer awareness.
Assalamu alaikum. I would like to, first of all, congratulate the organizers for arranging this wonderful event of community outreach. I'm a medical oncologist at Brody School of Medicine, and it's an honor to be here. I have been assigned the task of speaking about breast cancer awareness. Slides. Lower one, okay. So cancer as such is a very scary term, and it evokes a lot of negative emotions across the globe and across all strata of society. So what is cancer? Cancer it's a disease where in our body there are abnormal cells and they divide without any control. And these abnormal cells can eventually spread, and if they spread, it may lead to death. And cancer can occur in any part of human body. It's one of the leading cause of cancer, deaths across the globe. This year alone, around 2 million new cancer cases have been diagnosed in the United States of America. Many of us think that cancer is some remote disease which won't touch me, but unfortunately, it is very real, the risk. 1 of every 3 men sitting here or women can have, cancer in their lifetime if they live long enough. I hope, inshallah, it doesn't happen, but it's very real. 1 every 3 men, 1 every 3 women will have cancer in their life. So what about breast cancer? It is the most common cancer among women in United States of America. It is the second leading cause of cancer deaths among women. Around more than 300,000 new cases of breast cancer are diagnosed this year alone. In North Carolina, around 12,000 new cases of breast cancer. So what is the risk of, having breast cancer? For an average risk, that's a term you have heard throughout the evening, that means a person who doesn't have any extra risk factor. So you may think, I have no family member with cancer, so you may consider yourself as average risk. So your chance of having breast cancer is 1 in 8 in your lifetime, which is very rare. Men can also have breast cancer, by the way, but it is rare, but can happen. Again, we often think, okay, only people who have risk factor can get cancer. But breast cancer, the most common, I see breast cancer patients, and they have no risk factor other than their age and their gender. And these are factors that you cannot change. You're born with it. So your age, gender, and genes, but genes only account for about 15% of breast cancer. That means just being a female, and as you age, your risk of breast cancer increases. But thankfully, there are other risk factors that are under your control, and about 30% of cancers can be, avoided if we live a healthy lifestyle. So some of the factors that are under your control that contribute to breast cancer are taking estrogen, which is a hormone therapy after menopause, having the first child after the age of 30, or not breastfeeding, that will increase the risk of breast cancer. Being overweight, that's the theme. If you have to take one message today, that's having, leading a healthy lifestyle, not drinking alcohol, being active physically, avoiding radiation exposure will also increase your risk of breast cancer. There is some research showing working night shifts can also increase your risk of breast cancer. We are all blessed with a faith that has some of these things ingrained in it. My prior, colleagues have talked about how Prophet ﷺ used to advocate for eating, don't overfill you or don't overeat, be active, get a regular sleep. So all of that does contribute to your risk of cancer if you're not following, a healthy lifestyle. And all of this you can change. So what are the signs and symptoms of breast cancer? See, the goal of this event is that we want to find cancer earlier before it causes any sign and symptom. But nonetheless, it's important for you to know what could be the sign. Often it is a lump in the breast. You may feel any change in your breast, which would be it's swollen. It's one side is more swollen than the other. There's any nipple change. It could be there's crusting around the nipple. It could mean there's a drainage, especially bloody drainage. Skin irritation, if there is scaliness of the skin, dimpling of the skin, like the peel, orange peel, that the breast skin has changed and it looks like that. It's warm, swollen. That could all be, possible signs of cancer, but I don't think you should be alarmed if any of you or anyone you know has any of these symptoms, because majority of the time these can be benign, but you should not ignore it. Pain often is not the first sign, a symptom of breast cancer. It happens only when it's very advanced. In fact, early breast cancer doesn't cause pain. But nonetheless, if you have any of these signs and symptoms, the best thing you can do for yourself is to seek medical attention. So how do we diagnose breast cancer early? So screening is when you're finding cancer in a person that has no symptom, none of these signs. And you can find that by getting mammogram. So what is a mammogram? It's a specialized X-ray of the breast. So by getting an X-ray of the breast, it may look like either there is a spot there. Mammogram may show there's a calcium deposits there. But again, having an abnormal mammogram early on also doesn't mean it's cancer. It just means you may have to have additional investigation. So screening mammogram finds cancer when a person has no sign and symptom. So who should get mammogram? So there are different variation as to who should get, but generally any woman average risk starting at age 40 should be talking about mammogram. Between 40 to 44, you have option of getting mammogram. In my personal opinion is you should start then. 45 to 54, everyone should get mammogram every year. After 55, you can even go to every other year. It's based on some studies. But again, I think we had that discussion when Dr. Islam Ali was talking about age 75. The reason this number is 75, and we have our elderly, community members who are in good health. This is just a number. It's based on, after a certain age, if a person has other problems, finding a small cancer may not change their outcome. But that does not mean if you're 76 and you're in good shape and you should stop getting mammogram. You should continue it if you're in a good shape. When you should get mammogram may change depending on your family history. You may need MRI sometimes, especially if you are in that age group, less than 40, 30 years of age, and you have family members with cancer. So please, avail this opportunity. So what about Muslim women in United States? See, one thing about cancer is it does not discriminate. Whether you are a millionaire, whether you're a president of America, or whether you are some, someone who has nothing worldly, materials. Cancer affects everyone. And Muslim women are no special in that matter. We are also at risk for, cancer. Studies have shown that Muslim women generally have lower rates of breast cancer. That could be, marrying early, having kids early, some of the other risk factors. But unfortunately, studies have also found that Muslim women who have cancer, they're diagnosed at advanced stage, so they may delay seeking care. One study from Chicago showed that Muslim American women, the rate of getting screening mammogram was only 50% compared to 67% in the general population. There was another study about Arab American women, again, same theme. the rate of going for mammogram is lower compared to general population. Now, why is that? Of course, these are all perceived barriers. Why is this lower rate of mammogram among Muslim American women? I think one of the main thing is modesty concern. We worry, as you know, you may feel like you feel uncomfortable. Same with as I was talking about colonoscopy, that you may feel that you know, I'm exposing myself. But I want to assure you, all healthcare systems nowadays have female technician. From personal experience, also, you have the right. You can ask for a female technician. Modesty concern should not be a reason to delay, you know, mammogram. Right from the checking to the person who will be doing mammogram, it will be a female all team. And they are very courteous, making sure to ensure your privacy and comfort is maintained. Another perceived barrier is, according to studies, is fatalistic belief. And I see this also across other faiths, Abrahamic faith, you know, Christian patients I see. There is this thought that, okay, whatever is going to happen, it's in the hands of God. But again, I'm no expert in Islamic teaching. We have scholars here. But Islamic teaching encourages us, including Prophet ﷺ, said that, you know, our body is a gift from Allah, so you need to take care of it. And to that effect, screening can be seen as part of taking care of your body that Allah subhanahu wa ta'ala has given you. So I think this should also not be an excuse to not go for screening. The other, there are some cultural norms and stigma. You know, just talking about breasts can be uncomfortable. But again, Allah subhanahu wa ta'ala has given you body. Breast is a part of your body. I think there should be no shame in talking about breast health. There is heart health. There is also this. So we should be, you know, more open about talking these health issues. But again, this is a good step to start having these discussion, educational events. Also having just women-only educational events may also help. So I think, you know, we can definitely change the stigma. Language and health literacy, you know, generally you may be more comfortable in your mother tongue. Most institutions have translators available. All the national organization has educational stuff translated in various languages. You can go to Susan Komen website and print educational information about breast in Arabic or any language you want. Again, this should not be a reason to not seek. You know, you are in a country where we are blessed with a lot of, you know, opportunities educational. So, you know, getting a cancer that could have been avoided while you're living in America, I would say it's very avoidable. So breast cancer, again, while cancer is very scary, there is hope. Breast cancer is very curable. In fact, the overall deaths from breast cancer is slowly decreasing. Why is screening important? Because screening finds cancer early. Early cancer is very curable. In fact, stage 1 cancer, 99% chance of cure. So that is why emphasis is on to making sure you go for your screening mammogram, find cancer early and get it cured. One reason is I haven't, you know, I don't have slides about the treatment part, but just to give you an idea, the earlier your cancer is detected, less treatment you will need. The advanced your cancer is, more, you know, aggressive treatment and more toxic treatments you will need. So that is why, you know, going for screening is very important. What can you do to lower your risk of cancer? Oh, you have a few seconds. Okay, no, I have just 2 slides. Just exercise, you know, maintain healthy lifestyle, avoid, you know, estrogen therapy. And if you don't have insurance, that's also not a reason to not get screening mammogram. We have a monthly free breast clinic at ECU Health. If you are a woman 40 and over and have no insurance, you're a resident of Pitt community, please call this clinic and you'll get free mammogram. Thank you, Jazakallah.
Thank you so much. So we have 6 minutes at this time for Salat al-Maghrib for questions.
I don't need the mic on mine. So you said one of the risk factors that can be avoided is having the first child after age of 35. Do you suggest this for all women
So having children after 30 increases your risk of breast cancer. So, but of course there are various reasons. It's not, often, sometimes it's medical reason, you may not have a child. So, but in general, if it is in your hands and Allah's will, having children younger than 30 is associated with lower risk of cancer. But overall, across, different faiths, across different economic, the age at which women have children has increased. So that has also contributed to some increases.
So do you encourage them for like more frequent screening?
Yeah, not necessarily, just that if this person has not had, let's say has no children, that does not mean they need more screening. The screening guidelines are still based on average risk. So just not people who are what we call nulliparous, like they've never had any kid, does not mean additional screening. But if you want to lower your risk factor, definitely, having kids at a younger age helps. But I would say the biggest is, another thing is majority of the breast cancer, they don't have that risk factor. We have patients who have had kids less than 30 years, they still get breast cancer. So just being a female and as you age increases your risk, those other factors contribute, but not substantially.
If someone had breast cancer and had mastectomy, and normally they do mammogram for just one side. So what is the rationale of not doing mammogram for the mastectomy side? Because I think you can get back cancer, right?
Yeah, that's a good question. So the way mammogram is done, there's an X-ray of the breast. So when a person has had mastectomy, their breast is removed. You're right, they could still get breast cancer in that, because when a surgeon removes the breast, they remove what is removable. Some breast tissue is still stuck to ribs, but you cannot get an X-ray of that, because it's like you're pressing the breast between two X-ray films. Only thing what you can there is just whenever you bring breast aware, when people, they are taking shower, making sure on the side where there's no breast, around the scar tissue, that there's no new lump. But it's technically not possible because the breast is missing to do mammogram on that side.
We still have 3 minutes to Maghrib Adhan. So if you have any question in the from the previous presentation or for Dr. Mahwish, so you can have 3 minutes. We have a sleep presentation, we have a colon cancer presentation, and we have a reflux presentation. So if you have any question. Okay?
Thank you. Done.
You stay until
Okay.
I don't know.
Is there any relation between the panic attack and the sleep disorder?
First thing like I wanted to say earlier, when you go for any sleep issues or pulmonary issues to the ECU clinic, they will ask you that they are booked for 4 months or 5 months. Just tell them that Dr. Rahman has told us that I can be overbooked, and they will come and ask me, and I will see you on the same day if I am seeing patients, number one. So number two, as far as the panic attacks are concerned, like this can be mimicked, but there is no correlation between, I don't know any study, but if the patient has a having sleep deprivation, it will increase generalized anxiety. It will may increase the panic attacks also. Also, the patients who have epilepsy, they can have more epileptic episodes when they are sleep deprived. Also, when we are sleep deprived, our pain threshold goes lower. That means we will feel more pain. So patients with osteoarthritis should have proper sleep to lower their pain during the daytime. Also, we feel fatigued if we have sleep apnea. Sleep apnea, basically what it does is it gives you sleep deprivation. Sleep is not a depression. You are as non-refreshed as you slept. Although there are other like sleep-related issues like narcolepsy, cataplexy.
Just last comment, inshallah. As GI, we are four medical doctors out of 10 Muslims, and all of them are males, but there is other female sister in the community, so feel comfortable to get in touch with them, or even if we see you. Even if I see like men patient, sometimes they can be embarrassed that I do the procedure for them, so I refer to other colleagues who feel more comfortable. Jazakumullah khair. I'd like to thank Dr. Mavit. Jazakallah khair.
Thank you, Dr. Mavit, so much, and we appreciate the time and the effort you put for your presentation. We will stop here for Maghrib, Adhan, and prayer, inshallah, and then we'll resume with Dr. Walid and Dr. Mohad, inshallah, after that.
Inshallah, we should resume soon, inshallah. And maybe in the we learn from, as we go, maybe in the future we can make it less number of speakers, inshallah. We should start in 3 minutes, inshallah. My apologies for the brothers who couldn't take the questions. Just we have too many speakers. And there is event with the dinner, then the aza or the condolences. But the whole panel are available, inshallah. So during the asha, the community dinner, you can just pick, if you have question about colon cancer, ask me. About sleep, ask Dr. Zia. About diabetes, ask Dr. Mohit, and so on. We'll have a chance, inshallah, one-to-one during the dinner, inshallah. Okay. We'll wait for the brothers to make the sunnah and we'll resume our time. Jazakumullah khair.
ممكن تشوف يعني عشان الكاميرا شفتها خليك هنا فين الكف ده كنت اقف مكان الكف.
Assalamu alaikum. Let us resume our program, and the next speaker is Dr. Walid Saleh. He is a technical leader, research and development at Catalan Pharma. He has more than 20 years of experience in pharmaceutical industry. He will talk to us today about nitrosamine impurities or genotoxic impurities that disappeared lately in the food, cosmetics, and medicines as well. Let's welcome Dr. Walid.
Assalamu alaikum. I wanted to start with thanking Dr. Wael, Dr. Islam, and all of the show members and all of the organizers for this event and all of the attendees today. Thank you for coming today. So my topic is about nitrosamines impurities. I'm not sure if some of us, I'm not sure if some people heard about nitrosamine impurities or not. It's not important to know about the name, but it's genotoxic and carcinogenic impurities, and it's found anywhere in our world, and we're gonna see what's actually nitrosamines. So I'm not going into details of chemistry, but just to understand the principle of what we are dealing with, this carcinogenic impurities has this chemical structure. When we have like nitrogen atom, like adjacent nitrogen atom and double bond O, this is the chemical structure, but you don't have to memorize the chemical structure, but we're gonna see the principle. Where actually these carcinogenic impurities can be found, it's anywhere. It can be found in medicines, pharmaceutical products, cosmetics and makeup, skincare, in drinking water, in some types of food, and tobacco products. So, again, we are not going into details of chemistry, but we need to understand the principle how these carcinogenic impurities can be formed. To form this, we need amine, which is this structure when we have nitrogen attached to this alkyl or aryl group, and nitrites. To form this structure, again, it's the nitrosamine carcinogenic impurities. What we just need to memorize, we don't need details of chemistry, but just to memorize, we need to form this carcinogenic impurities, we need amine and nitrites, and a chemical reaction can be enhanced for some reaction conditions, which might be like high heat or high humidity or acidic conditions. Why it's actually carcinogenic? Millions of studies, we don't have the time to explain that, but for some of the studies, they injected a rat with these impurities, and they found that the DNA structure we have, for anybody studied like basic biology, the DNA, it has some nucleotides called guanine and cytosine, and in the normal condition, we have this like guanine attached to cytosine. And when they injected the rat with this nitrosamine impurities, they found that alkylation or the structure of DNA is changing, which means like our DNA, we started with this and we ended with adenosine and thymine, which means like these impurities can cause mutagen. It changes your genetic information, which is mutagen in your DNA. So let's see different categories where this nitrosamine can be found. Let's start with water. Again, if you remember, we said amine, nitrite to form these carcinogenic impurities. What about water? Some cities, they use disinfectant for water. Some cities, they use chlorine. Some cities, they use something called chloramine to disinfect water. What about Greenville City? In Greenville City, actually, they use both chlorine and chloramine. So again, we have amine source, and if we have nitrite, it will form some carcinogenic impurities. So should we care about water? Let's see. The good news that we were able to get, we contacted actually Greenville Utility to get the results for the water. And the good thing that they have the nitrite, the maximum level is 1 part per million, and it's a random results in April and through August of 2025. And all of the nitrite results way below the acceptable limit. So it's very unlikely for the water to have these carcinogenic impurities. So it's good, don't worry about water. The only thing that we found here is just the chlorine content is, the maximum level is 4 parts per million, and for some days it was at the border. Chlorine is not that toxic, but it's easy to get rid of chlorine if you are using very cheap, like $20 carbon filter, it will get rid of the chlorine from water. But for nitrosamine, it's very unlikely to have it in water. Okay, what about food? Many studies they found processed meat and some type of canned fish like herring or فسيخ and this stuff, they have a lot of nitrosamine. If we look at this study for processed meat, actually how they prepare it, they introduce the meat, they add a lot of preservative, it's called sodium nitrite, to keep the meat as long as fresh for many months. And these nitrites, if you remember again, nitrites and amine, and actually the red meat and fish, they are actually naturally a very high content of amine. So again, you are reacting the amine and nitrites to form these carcinogenic impurities. Here, the highest carcinogenic content found in bacon, and even if we have like halal bacon, and under this category we have also like pastrami, any processed meat that has a very long shelf period, they have nitrites added to it, it's carcinogenic. Please get away from this product. We are also sausage. We are not talking about the fresh sausage that you can get from the Arabic store. We are talking about the cured or processed sausage, which you can find in like Walmart, in package, and they have a very long shelf life because they have a preservative. High content of nitrites, it can react with the amine to form these carcinogenic impurities. We have actually, for the last 2024 and 2025, more than 1,000 lots of products, food, they are recalled from the market, and this is one example of halal chicken sausage. It's removed from the market for high content of nitrites. As we said, this might be carcinogenic. What about cosmetics? We are not going into details of cosmetics. This is a barcode. If somebody wants to study more about what can be happening in cosmetics. But to summarize, just look for any ingredients for cosmetics, makeup, skincare. Always look for those two components, DEA or diethanolamine, TEA or triethanolamine. These two ingredients, it's easily absorbed from the skin and can accumulate in your liver and your kidney. They can form a carcinogenic compound. Its name is N-nitroso-diethanolamine. So whenever you see DEA, TEA, don't get this cosmetic or this skincare product. Let's see about some examples from the market. This is very famous, soup bar from Neutrogena. If you look at this compound, triethanolamine. Again, don't get that. Another product famous from the market, Olay 7-day aging, anti-aging. The first ingredient, they make it easy for us, triethanolamine. Don't get it. What about cigarettes and tobacco products? They actually discovered more than 6-7 carcinogenic impurities in tobacco products. But the most famous, anybody knows that tobacco has nicotine. So this is the chemical structure of nicotine. Again, we said nitrogen when it's adjacent like to alkyl group. This is tertiary amine, which is medium risk. Secondary amine is more susceptible to form these carcinogenic impurities. But when they process actually the tobacco products, tobacco leaves to dry it, it's forming this compound is called nornicotine, and this is a secondary amine when we have the nitrogen attached to hydrogen, and this is very easy compound to form N-nitroso-nicotine, which is carcinogenic compound. So every day we have studies that showing us smoking is carcinogenic. So hopefully we ask Allah to protect all of us from this. And now in pharmaceutical products or medicine, most of us remember this medicine, Zantac. Zantac is actually used in treating the peptic ulcer, H2 blocker to treat peptic ulcer. And FDA FDA in 2019 requested a warning letter, and then they removed Zantac from the market for carcinogenic nitrosamine impurities. First, they asked for investigation, trying to get the nitrosamine impurities lower than the accepted limit, and they failed to get into the acceptable limit, and Zantac is completely removed from the market. Why this Zantac compound or ranitidine compound has a special case we're going to see now. And actually, Zantac was not the first case. We have many medicines showing that nitrosamine compound, but they were able with some risk mitigation to get that risk below the acceptable carcinogenic limit. Some of these examples, valsartan, it's very famous antihypertensive drug. Pioglitazone, metformin, it's for hyperglycemia, and always the case is nitrite and amine during the manufacturing of the drug product. But what was special about Zantac or ranitidine? This is the chemical structure of ranitidine, and as we remember, we said nitrite and amine, they form carcinogenic compound. This is the chemical structure of ranitidine molecule. It has nitrite and amine on the same molecule, so there is no way to prevent that. This compound can easily break in this bond to release amine in your body, and amine can react with nitrite to form, this is very carcinogenic impurity. To explain how is the level of carcinogenicity of this compound, imagine if you can, very famous like Tylenol, you can get like 8 tablets per day, which is like 4,000 milligrams per day. This impurity level, the toxicity level is 26 nanogram per day, and nanogram is 1/1,000,000 of milligram. Can you imagine how toxic is these impurities? But the news just in 24 of November, just 2 weeks ago, after 6 years of absence of Zantac, Zantac is coming to the market again. They were able to do some reformulation to protect the compound from degradation. However, it's still risky. So for our doctors, they prescribe Zantac. FDA actually released some notes. If you anyway going to use Zantac, you have to take this advice. If your pharmacy prescribe you like 2 bottles, only open 1 bottle at a time. If you have a bottle of Zantac, when you open it, you will find something called silica gel. It's sachets that definitely don't eat it, but also don't throw it in the trash. Just keep it in the bottle, because this absorbs the humidity and keep your drug product away from the humidity. Also, don't dispense your drug product. Some people, they have a dispenser to add, like, this is a tablet of Saturday, Sunday. Don't do that. Keep the drug product or the medicine in its original in the original bottle. Okay. Now we are talking about what actually the pharmaceutical companies do to protect us from the nitrosamine. Just for knowledge, we are doing like risk assessment for all of the facilities, all of the the possibilities of cross-contamination. We also, for many medicine, it has something called API, or the active pharmaceutical ingredient, like the paracetamol in case of Tylenol. And also it has some inactive ingredients like lactose, saccharose, which is inactive, to add like a volume to the drug product. We, in the pharmaceutical company, we try to find the lowest nitrite grade to protect the drug from formation of these nitrosamine impurities. We also do like formulation studies to keep like lower heat for the formulation. We also test for these impurities. It's as we said, it's carcinogenic at nanogram per ml level. So we have very specific and very sensitive techniques, like it's called like liquid chromatography mass spec or gas chromatography mass spec. We also do stability study, which we we expose the drug product or the medicine to harsh condition, high heat and humidity, and to test for these impurities, how it can form when we have harsh conditions. This is very nice study. It shows that when they added vitamin C to our formulation, it significantly reduces the formation of nitrosamine. What does it mean? It means like if you can get antioxidant or vitamin C as a supplement, it protects your body from these carcinogenic impurities. To take home, water, should we care about nitrosamine? No. And chlorine, as we said, we can use just easy filter, carbon filter. For food, please get away from the processed meat, the canned fish, and always look at the ingredients to be free from nitrites as a preservative. Tobacco products, it's carcinogenic. For cosmetics, again, remember, all of the ingredients should be free from TEA or TEA. For the medicine, tell your doctor if you have any family history of cancer. Always keep your medicine away from heat and humidity. The pharmaceutical company, it gives you the expiration date. The medicine is safe, pure, effective if it's stored at the original recommended storage condition. Don't expect when you add your medicine in the glove box in the car, it will be safe until expiration date. And as we said, vitamin C is really helpful to protect you from these carcinogenic impurities. And thank you, Randy, for your questions.
We have 5 minutes for questions.
Sure.
You said we keep the medicine until the expiration date, but some people say even if it is expired, we still can take it, but it's going to be less effective.
Very good question. Okay. Actually, I entered my college in pharmacy in 1998. And at that time, we had Dr. Yassin Hamza, may Allah bless him and Allah yarhamu. He taught us that we had a definition for the expiration date. What is actually the definition of expiration date? It's defined as the date at which 90% of the active pharmaceutical ingredient is like 90% is still there. Which they taught us, okay, what about like 90%? It's still good, so we can take the medicine even after the expiration date. But this definition is no longer valid. Because at that time, we had nothing at these days, it's called related compound. What about this 10%? You said, okay, we have the active is 90%, but you don't know what is the 10% is now. Some of them may be carcinogenic. Some of them might not be carcinogenic, but still harmful. I'll give you example, aspirin. Aspirin, it's called acetylsalicylic acid. If you just keep it after the expiration date, and if you smell it, you will smell a vinegar because it degrades to form acetic acid. If you keep it even before the expiration date and it's stored in a bad way, it will still form acetic acid. So it's not recommended. We don't say it's just on the day expiration date, so the following date will be carcinogenic. Definitely not. But I mean, if it's not that important to take the medicine after the expiration date, just don't do it. Thank you. Alaikum assalam.
So you said we can take antioxidants to prevent carcinogenic. So where do we get these antioxidants? Is it from food or what kind of food?
Yeah, I mean, as pharmaceutical company, we try to find a risk mitigation to prevent this formation of carcinogenic impurities. So one of the studies they found when they add a small amount of vitamin C to the formulation, they found a huge, significant loss of the nitrosamine carcinogenic compound. From this, they found that the regular people, they can go to the medicine, it's something over the shelf, vitamin C. Everybody can get vitamin C tablets. It will help your body, even if you have some nitrites and some amines. vitamin C is acting as a scavenger to the nitrite. It's antioxidant, so it will scavenger the excess nitrites and protect your body from this compound to react inside your body, especially when it touches your acidic content of the stomach. Thank you.
It boosts our immunity.
Sorry?
It boosts our immunity.
Yeah, sure.
Yeah,
There are
thank
some-
you.
There are some conditions where vitamin C is contraindicated to other health reasons.
Yeah, sure.
So they have to consult.
Yeah, sure. You should consult your doctor if somebody they have like peptic ulcer and vitamin C can affect them. So any medicine you should contact your doctor. Thank you.
Thank you, Dr. Walid, so much for this informative presentation. And one comment, funny thing, when I went to try to find Zantac in the pharmacy store, and I found that they already manufacture Zantac again and put it on the shelves. But when I looked closely at the pamphlet, I found that they changed the active ingredient from ranitidine to famotidine, and they still keep the same brand name of Zantac. So make sure that you are, when you go to take Zantac, it is not actually the right Zantac, but they changed the active ingredient. Let's welcome Dr. Mohit Dar. He is a staff endocrinologist, Department of Veteran Affairs, Clinical Associate Professor of Medicine at ECU Health, with more than 11 years of experience in the field. He's going to talk to us about type 2 diabetes. Let's welcome Dr. Mohit.
Okay, just advance here. Okay. You can.
Assalamu alaikum. Thank you to the Shura for giving me this opportunity, and thank you for coming. So, inshallah, I'm going to be talking about type 2 diabetes, just to give you a sense of how common type 2 diabetes is. In 2024, approximately 589 million people had diabetes, and the general age was from 20 to 79. And it's projected in 2050 that approximately 853 million people by 2050 will be living with diabetes. So obviously that's a very high number. We're approaching a billion, so this is a major problem. The other thing that I wanted to highlight is 252 million people living with diabetes are undiagnosed. So the other thing to remember with diabetes is that often it doesn't become apparent that you have diabetes until the symptoms become more severe. So let's just define what diabetes is. So diabetes is a condition when high glucose levels in the blood eventually lead to damage in small and large blood vessels in the body. It's very important, we think about sugar, high sugars, diabetes, high sugars, but it's very important to realize that diabetes is a disease of blood vessels. Blood vessels, okay? And there are large blood vessels in our body. There are large blood vessels that go to our heart. There are large blood vessels that go to our brain. There are large blood vessels that go to our legs. So it can impact those vessels in our body. And then there's also small blood vessels that go to the nerves in our feet. They give us sensation of where our toe is going, heat, sharp, a sense of balance. There are blood vessels in the kidney that are involved in kidney function, and there's also blood vessels in our eyes that give us vision. So when you have diabetes, you have a risk to develop complications in these two regions, small and large vessel complications. The other thing to realize is that when you look at why people die from diabetes, they die from large vessel complications, heart attack, stroke, and also kidney disease is very significant in diabetes. So if you have diabetes and your kidney function is declining, and especially, God forbid, astaghfirullah, if you have to go on dialysis, you have the highest risk of dying from a vascular event. So avoiding progression of kidney disease is really important. So this is helpful to think of as an endocrinologist. If I see a patient for diabetes, what are my goals? I certainly want to improve glycemic control, but I also am thinking about the heart and the kidneys. And we know that, remember we talked about the small vessel complications, nerves in your feet, kidney, eyes. We know that there is a close link between blood sugar control and small vessel complications. But for some reason, we don't know why, but there's not as clear a relationship between blood sugar control and the risk for large vessel complications, the heart attack and strokes. So if you have good control, your risk for small vessel complications will be lower. If you have good control, maybe 5-10 years from now, your risk for heart attack and stroke will be lower, but that relationship is not as tight. So there's 40 plus medicines for diabetes, so I'm not going to go over every one, but I wanted to bring to your attention, there are 2 drug classes, okay? In the last 10, 11 years, these 2 drug classes have emerged that show that if you take these medicines and you have diabetes and you've had let's say you have diabetes and you've had a heart attack or a stroke or you have kidney disease. So they've found in the last 11 years that these 2 drug classes, Jardiance is part of one, we call them SGLT2 inhibitors, and Ozempic are part of a class of drugs called GLP-1. These 2 drug classes obviously lower glucose, but they've been shown to help people live longer who've had cardiac events like heart attack or stroke or bypass. They also help delay progression of kidney disease. So they've been shown to prevent someone from having to go on dialysis. So that's very important. The other thing is that a lot of patients that have diabetes, they're overweight or they're obese, okay? And a lot of the medicines before these drug classes came along would add even more weight. So imagine someone has diabetes, you put them on insulin or other medicines, it causes them to gain weight. It does improve their blood glucose levels, but it causes them to gain weight. These drug classes, Jardiance leads to about 1 to 2% weight loss. Ozempic can lead to 5, 10, 15, or even 20% weight loss. So now the cutting edge of diabetes care is that you have medicines that obviously lower glucose, but they also help with weight loss. They curb appetite. They lower your chances of having a heart attack or a stroke, and they also prevent or delay progression of kidney disease. So that's the future of diabetes treatment. This is just a figure for those of you that may have diabetes. For those of you that have diabetes, you've probably heard of A1C. It's a 3 to 4 month measure of glucose control. And this is a graph that shows, or a chart that shows kidney function. If you go to your doctor and they say, your kidney function is at 50% or 80%, normal is 90%, okay? So let's say you have kidney disease. Kidney disease progresses through different stages. So if you have 90% kidney function, that's normal. If it's 60 to 89%, it's stage 2 kidney disease. 45 to 59% is stage 3. When your kidney function drops below 30%, that's stage 4. And usually the patients that need dialysis, their kidney function is usually below 20%. So our effort is to prevent patients from reaching into this range. So some of the new technology is that when people, let's say someone has diabetes and they want to know what their blood sugars are doing, we used to have patients come in, you have to prick your finger, bleed, you take that drop of blood, you put it on a test strip, you stick it into a glucose meter, and then after a minute you get a glucose reading. So if a patient was doing really well, they were checking 4 times a day. But obviously just imagine having to prick yourself 4 to 5 times a day, every single day, and do that day in and day out. Now there's emerging technology, the picture's not very good, but it's about the size of a quarter, and you place it beneath the skin, and there's a small probe that measures glucose continuously. You can download an app on your phone, and it gives you glucose in real time. So these are called continuous glucose monitors, and so for a patient and the doctor, it's very helpful. You can know what your glucose values are doing at all times. So let's say you eat a meal, and you can see how it's affecting your blood sugars. When a patient comes to us, I can go through that, and I can see for the last 30 days what they've been trending, where they've been having lows. So this is very revolutionary, because some patients that I've seen who had very poor diabetes control, they're eating inappropriately, they get put on the CGM, and it gives them insight into what they're eating, and they change how they eat. It's very important. The other thing is that insulin pumps have really exploded. You know, it used to be an insulin pump is a device that has insulin in it here. The insulin goes to the tubing and it goes into the skin, so you don't have to do injections. And then it's connected to a continuous glucose monitor. And the technology is advancing to the point where if a patient is on an insulin pump, they have a continuous glucose monitor and they have an insulin pump, and they're talking to each other. And you're telling the pump that I want this patient to be at 130, and the pump is making adjustments on its own using algorithms. And basically, probably within 5 to 7 years, it will be what we call a closed-loop insulin pump. You put the pump on, the CGM, they're talking to each other, and it's continually adjusting the insulin to keep your sugars controlled. So, you know, the AI and those types of technologies are really improving diabetes care. So how is diabetes diagnosed? So A1C is the easiest way. If you go to your doctor and you ask them, hey, I have a family history of diabetes, I'd like to be screened for it. And A1C is a 3 to 4 month measure of your glucose control. You can also do a fasting glucose. You don't eat for 8 hours, you come. If it's greater than 126 or more, you have diabetes. And a glucose tolerance test, we don't really do that very much, but kind of in the past, you would drink 75-gram glucose load, and then at 2 hours, if your glucose was greater than 200, you had diabetes. Also, if a person just comes in the hospital and their sugar is greater than 200, that's another way to diagnose diabetes. So I think this is more important to our community. If you don't have diabetes, obviously prevention is much better than someone having diabetes. So who should be screened for diabetes? So if you're 45 or older, that's helpful. You should ask to be screened. BMI stands for body mass index. And in the announcements, you know, the WhatsApp group, I sent a calculator for what's called BMI, body mass index. You take your height and your weight, and it gives you a BMI. So if your BMI is between 25 and 29, you're overweight. If it's above 30, you're obese. If it's above 35, you're morbidly obese. So if you're obese, you have a risk factor to develop diabetes. Any family history of diabetes, if you're not active, there are particular risk groups like African Americans, Latinos, Asians, South Asians especially, you know, people that are from South Asia. We don't, you know, you don't have to be as heavy or overweight or obese to develop diabetes as someone who's like African American or white. So there are ethnic differences as well. If you were pregnant and you developed gestational diabetes, you have a higher risk to develop diabetes. If you have high blood pressure, if your cholesterol is elevated, if you have a history of heart disease in the past, those are all risk factors for diabetes, and you should be screened. So prediabetes, as I mentioned, if your A1C is between 5.7 and 6.4%, you have prediabetes. What that means is that that means you're at risk for developing diabetes. And then also, if your fasting glucose is 100 to 125, you have a risk to develop diabetes. I think I already talked about this, that, you know, these are the different ranges of obesity. I'm not going to talk too much about that. But this is important, I think. How do I stop prediabetes? Because we're talking about prevention, right? The most effective way to prevent diabetes from happening is physical activity. It's recommended to do 150 minutes of physical activity, and that can be walking. You don't have to run a marathon, but no more than 2 to 3 days off, and you try to total 150 minutes per week. Sorry. And that could be, you know, walking, riding, swimming, anything to get active. And also, it's known that if you exercise in groups or with your spouse, that there's a greater likelihood to exercise and keep to it. And then this is a hadith that I just wanted to read to you. The Messenger of Allah said, "A human being fills no worse vessel than his stomach. It is sufficient for a human being to eat a few mouthfuls to keep his spine straight. But if he must, then 1/3 food, 1/3 drink, and 1/3 for air." This hadith is 2,000 plus years old. But we know now that portion control is also very important. If you eat less, your diabetes will be better controlled. So portion control, I think, is really important in combination with exercise. This is a picture of my grandfather. And diabetes runs deep in our family. And he also, from what my dad tells me, he was a very fit guy. He played field hockey, and then he developed diabetes. And then I think at the end of his life, from what my dad tells me, he died of kidney failure. So it's really important for us to prevent these types of things from happening. And so the best thing that you can do for yourself if you have prediabetes is to become more physically fit, exercise, and to cut down how much you eat. Thank you.
Thank you so much, Dr. Mark. We have a couple of minutes for questions.
What's the best food you could eat it, making your sugar go down?
That's a tough one. We know that generally the Mediterranean diet, which includes, North Africa, Muslim countries as well, it's generally considered to be heart healthy, but it's the amount of food. So again, portion control is important. They've actually done newer studies indicate, we have to fast in Ramadan. So fasting is actually a good way to, control blood sugars or to prevent diabetes. It's not that when we develop diabetes that we can't make insulin. That's what lowers glucose. But when you eat a lot, your body, your muscles, they get resistant to insulin, so you're not able to lower your glucose values. So you can eat food, but it's the amount. So, yeah.
I tried the Descom, and I used to be 8.5 A1C. Now I'm 5.6.
Okay, that's good. That's good. Brother Gaza?
We go back to the two medications that you have said, mentioned earlier. Now there's a hype on the internet for healthy, overweight women and men, and they use these medications to lose weight.
Right.
Obviously, every medication has some side effects, and I know these medications prolong, the life of people who have diabetes, could prevent cardiac arrests and delay, kidney disease. But I want your, advice or opinion about, men and women who use these healthy, not ones who have diabetes, for the purpose of losing the weight,
That's a very good question. So, the first thing that's important to realize is if someone is overweight, if you're obese, these drugs, especially not the Jardiance, the tablet, but the Ozempic, it also has an indication that the FDA has approved to help with weight loss. And I think if you're obese, obese, BMI greater than 30, you can use a calculator that I just sent. You have a high risk to develop sleep apnea, as Brother Zia was mentioning. You have a high risk for GERD. You have a high risk for sudden cardiac death. You have a high risk so if you're obese, that's a big risk factor. And so it kind of depends on if the person is obese or not. If they're not obese and they're normal weight and they're using it to, become thin, that's not appropriate. But there are people that are abusing it in that way. So I would not recommend it for that. But if someone is obese but not diabetic and they want to use it, that's a reasonable use of it. Yes, Ron.
On patients using ACT, aspartame ACT, and metformin related to gastronomic activities in the body. How can we relate it as the previous speaker said?
You're talking about the nitrosamine?
Yes, aspartame ACT and metformin.
That was more of an impurity. It's not that every single tablet of metformin has it. It's more like an impurity in the manufacturing process. And so that is more of a batch of metformin tablets that had it. But it's not that. It doesn't mean that every person that's taking metformin is consuming nitrosamine. It's just, imagine manufacturing millions and millions of tablets sometimes the process breaks down or there's an impurity and they have recalls. But I would say generally metformin has been around for 50 years, it's safe, but there can be batches where you have contamination. Just like, the sensors we were talking about, there sometimes can be defects in their recalls. So it generally is safe to take.
Thank you so much, everyone. Let's thank Dr. Moh for this informative session. And before I end, I really, really want to thank every one of you. I didn't expect that all of you will join us today. So thank you so much for joining us. And inshallah, in the future, within 3 months to 6 months, we're gonna repeat it again. And if you have any question, please go ahead. Our panel is still here, and they will gonna have dinner with us. So please, if you have any question, you can go and directly chat with them. And before I end, I want to thank Dr. Islam Ali for his presentation, Dr. Mohamed Dar, Dr. Walid Saleh, Dr. Muhammad Khalaf, Dr. Diya Rahman, and Dr. Mahvish Muzaffar. Thank you so much for joining us today, and let's enjoy our dinner.
Just a reminder that we have Aza, so we need to be done please by 6:30 inshallah. So we can enjoy the food, and if you have any question, you can ask whoever you want. And 6:30 we should be done, inshallah. Light on, please.
We have our own lives.
Thank you very much. Jazakallah khair. Good work. Jazakumullah khair, guys.
Thank you. Wow, thank you.